Hey everyone, and welcome to the FLATLINING Podcast from Fulcrum Strategies. I'm Matthew Handley, and with me is our president and CEO and economist, Ron Howrigon. Ron, how are you, sir?
I am doing well, thank you.
Now, I promise we aren't getting totally away from video. We had some technical difficulties this morning, which is also part of the late delay on this podcast, but nonetheless, we're here to talk about some of the important healthcare headlines and how they're going to affect providers and patients. And perhaps the economy as well, Ron, as we get into it. And the first thing I want to talk about, Ron, is one of our favorite insurance companies, and that's UnitedHealthcare. And this story comes out of Minnesota. And this was originally published in the Minneapolis Star-Tribune. And in the state of Minnesota, the legislators there have blocked for-profit HMOs from being a part of their state Medicaid plans. This is being the managers for the Medicaid plans. Ron, we've talked about before some of these for-profit HMOs. Some states have them. My state of Michigan has one for Blue Care Network. So how do some of these, first of all, before we talk about the Medicaid portion of it, what's the purpose behind having a for-profit HMO versus the traditional HMOs? For example, like in Michigan with Blue Cross, you've got Blue Cross Blue Shield, and then you've got Blue Care Network. What's the reasoning behind that?
The reason why the different Blue Cross, or just
in general, HMO? why you would want a for-profit HMO as opposed to a nonprofit?
Well, it's one of the things that it begs the question is when you get profit motivation, and again, we've talked about this before. There's a lot to be said in a free market economy for the old Wall Street movie statement: greed is good. Because it pushes you to be better. And there's a lot of areas where greed is good. Apple makes a lot of money because they make a better product. But the question becomes, when you get into healthcare, is greed really good? Is the profit motivation really good? Because of some of the inherent conflicts on what's good for insurance company profit, it may not be good for the patients or the doctors. And I heard somebody the other day coin are we talking about budget care or patient care? Because those can be two different things. So and that is the underlying question: is should there be a profit motivation in health insurance? And it gets even bigger question when you talk about publicly funded healthcare for, in essence, for poor people and people with certain disabilities in Medicaid.
So the Medicaid program, as you just mentioned, is publicly funded. It's for those that either can't afford. They're below they have a certain percentage, I believe, of the poverty level, or they've got certain disabilities.
Yeah.
And it's a benefit that we provide to those people, and it's paid for through our taxes. Now, are there any states around right now that you can think of that don't contract out the Medicaid portion, the manager of the Medicaid portion, to a third-party administrator?
I think there's still a couple that don't have managed Medicaid. Most states have some form of a managed Medicaid program where, they contract some or all of their Medicaid population out. Very similar to, Medicare Advantage plans, that kind of stuff.
And in principle, that makes sense as a consumer. You look at it that if the state doesn't want to have to try and hire a bunch of people to manage that program, they can, in theory, contract out another company that's going to do it for them cheaper, save the state money. But at the same time, now we're getting into the profit motivation thing that you just talked about. So the state of Minnesota has used HMOs for years, decades even, to be their managed, to run their managed Medicaid program. And they're dropping out of the for-profit HMO options for that. According to the Minneapolis Star-Tribune, the market was reserved for nonprofit health plans up until 2017, which the state legislature then overturned a 40-year ban on for-profit HMOs, but it appears they have recently decided to reverse that and again ban those for-profit HMOs. We talked about the profit motivation there, budget care versus actual patient care. Does it really make a difference, though, when you're contracting it out to one of these large insurance companies about whether or not the Medicaid is managed by a for-profit or a nonprofit HMO?
Well, to me, I think there are probably two questions. One question is the appearance, what it looks like when you've got a very profitable entity, publicly traded entity like United that makes billions of dollars, what it looks like when they're making money off of state and federal funds. There's that appearance problem. Even if they're doing absolutely everything correctly and they're being incredibly efficient, there's still that appearance problem because, part of what we've got here is a United Healthcare making more money per enrollee on Medicaid than they do on employer-based care. I mean, it's more profitable.
Mm-hmm.
Medicare is more profitable.
Yeah.
And then you've got the physicians who are providing the care saying, wait a minute, this is the patient I received the absolute lowest reimbursement on, but I've got a for-profit publicly traded insurance company that makes more profit on this individual than a commercial insurance. So there's that appearance problem. Now, the second question, which I don't think has been answered, is: are the nonprofits any better? Are they doing it better, cheaper, faster because they don't have that profit motivation? I don't know that they aren't.
Sure.
But I don't know that they are either. I haven't seen any good data on that. So I think this may be, at the legislative perspective, just purely getting rid of the appearance problem. And maybe it gets rid of another problem too. I don't know. We haven't seen good data on that.
Well, and it's interesting you bring that up because as we've talked about before, Blue Cross Blue Shield of North Carolina got the okay from the state legislature that they can operate more like a for-profit company, even though they are still technically a nonprofit. So that falls in line with exactly what you're saying. Is it better? And the answer is we're not entirely sure yet. Of course, to be totally fair, United Healthcare is not happy about this ban. Of course, United Healthcare is based there in Minnesota, in Minnetonka, and they are they think that this is purely targeting them and their Medicaid line of business there in the state. Last question on this issue, Ron, I want to talk about is HMOs in general versus some other health plan for the Medicaid. In theory, again, as a consumer, this makes sense to me only because you're supposed to be coordinating through a primary care provider. Are you aware of any evidence that shows that has healthier outcomes for Medicaid patients by having all of that coordinated through a primary care provider?
Well, there's definitely evidence out there that says that the more individuals seek coordinated care from a primary care provider, the better the outcomes. There's a lot of data that shows that, and it's one of those things where you look at the data and you kind of go, well, of course, I mean, if I'm a 45-year-old male and I'm seeing a primary care physician, they're going to be looking at my cholesterol levels. They're going to be looking at things, and that helps. Now, the question becomes, like, say in a Medicaid environment, do they actually increase the amount of primary care that gets delivered, or is it just, well, you were assigned a primary care physician and therefore it must be better? I mean, it's more than just saying that's your doctor. You have to go to that doctor. Mm-hmm. And I haven't seen much data that says that they really improve the percentage of time that people go to primary care and that there's better outcomes. It may be, I just haven't seen any data on that.
We'll link this story to the Star Tribune in the show notes for this program, as well as at flatlining.net. Ron, I want to switch gears to another hot button issue right now, and that's those GLP-1 weight loss drugs, such as Wegovy and Mounjaro. Federal lawmaker, which would be Bernie Sanders, has warned in recent weeks that weight loss drugs have the potential to bankrupt the U.S. healthcare system, and a new study by Blue Cross Blue Shield found that 6 in 10 patients taking the drug don't reach a meaningful health benefit. I want to dive into both of those because I know Wall Street's very bullish right now on these GLP-1s and how they can at least make investors money. We hear a lot from people, and I know you shared your testimony here before as well about how these can have very good health benefits. But I want to start with Senator Sanders' remark that it's going to bankrupt the healthcare system. It's to my knowledge still that most of these drugs are not covered by commercial insurance, and I don't believe they're covered by Medicaid for weight loss. So what are we seeing right now with, is Bernie Sanders predicting that they are going to be covered, and now we're going to have very expensive drugs bankrupt the system for Medicare and some of these other programs? Or what do you think he's predicting here?
Yeah, I think that's exactly what he's predicting. I think he sees correctly, I think, the fact that it is going to be extremely difficult, more and more difficult, to not cover these drugs. because we're getting more and more clinical data on their impact on things like cardiac risk. We know intuitively that there is a massive amount of downstream healthcare problems through obesity.
Mm-hmm.
We also know that it's a huge problem in this country. If you compare the obesity levels in the U.S. compared to, our similarly developed countries in Europe, Germany, England, France, et cetera, you are 40% more likely to be obese in this country than you are in Germany. That's huge. And the
Mm-hmm.
cost side is huge. So as we get more and more data and everything from cardiac effects, there's people that are starting to say, well, what effect could it have on, let's say, total joint replacements? If people are carrying around a less weight, they're less likely to need a hip or a knee replacement. So I think what Bernie's saying is it's going to be almost impossible not to cover these drugs in the future because they have so much clinical benefit. And then once we cover them at their current cost, it's breaks the bank. And I agree with the math on that.
Yeah. And we've talked about that before. And actually, we even talked about some of those stats last week on our program with our conversation with Lou Tharp. Of course, he's talking about it particularly from a public health perspective and changes in lifestyle. And it was a great interview, and I encourage everyone to check it out wherever you listen to podcasts. Back to the GLP-1s, though, some state health plans, meaning Medicaid, have decided, and CHIP, have decided to start covering some of these. I haven't seen yet any numbers on how that's affecting certain states, but I undoubtedly it's got to be costing these states more money.
It does, and I think part of the problem here is I don't think anybody's taking a look at this the way to say, all right, these drugs have enormous benefit. Now, they should only be prescribed for the right people. This is not to get somebody into swimsuit
Right.
condition. It's not for the last 5 pounds. This should be clinically cleared for people who are morbidly obese, who have a problem. It should be prescribed and followed by a physician to make sure everything's doing correctly. You've got to make sure you get enough protein in your diet when they're on these, et cetera. But in the right situations, they should be covered. And where I think we're missing the boat here is whether it's an insurance company or a self-funded employer. We've got two drugs out here who are very similar. You've got Wegovy and you've got Zepbound, and there are others now that are coming too. If I were a large employer group and I say, look, I want my people to be healthy, and first of all, I want to make sure that only the right people get this. Again, it's not for that last 5 pounds. But I'm going to go to both manufacturers and say, look, the guy who gives me the best price gets all of it.
Sure. Yeah.
And make them compete. I think then you're going to start to see the market drive the price down. But the long-term benefits are just staggering. I'll give you I've struggled with a weight problem my whole life. Okay. I started on back in January of 21, started on Wegovy. Zepbound wasn't really out yet, the Mounjaro drug. In the first 6 months, I lost 33 pounds. Okay. But then my insurance company stopped covering Wegovy. So they switched me to a much less effective pill form. In the next 3 months, I sort of maintained that weight, but didn't lose anymore. Then I went off that because Wegovy wasn't covered, and it's $1,000 a month. And I gained back most of the weight. Okay. I went back on now Zepbound, and I'm paying for it myself, and I've dropped all that weight again. So I'm down, 45 pounds. Not only does that make a huge difference that I'm still losing weight, but all of my numbers with my primary care physician are much better. My blood pressure's down. My cholesterol now is down below 100. So by all markers with this one drug, I've been able to elongate my life expectancy, reduce my risk of cardiac disease. I've got really no risk of diabetes right now. All of these things. Now, is the drug too expensive? Absolutely, it's too expensive. But is it effective? Oh, hell yeah. For the right people and you follow the program, it's effective. I would strongly challenge where this 6 of 10 patients didn't receive a meaningful health benefit garbage, because that's not what the clinical studies show. And again, my situation is only anecdotal. It's not what I've experienced.
Right. And I want to come back to that, but I want to work off a point you just made there, because we had this conversation, I think, a year or 2 years ago here on the FLATLINING Podcast. And I'll admit, I was skeptical of the idea that, people should be satisfied with taking a pill every day or an injection in the case of these drugs, these GLP-1s, taking a pill every day to to maintain a healthy lifestyle. However, we've had conversations, I've done more reading on it, and this is one where I can say my mind has been changed because exactly like what you're talking about. It does provide a significant health benefit, not outside of just the weight issue. Talking about specifically blood pressure and some other benefits as well. So it'll be interesting to see as this goes on. And I like your analogy they were talking about, or the example they're talking about, having companies decide which one to pick, because it's the same decision they choose whether or not they're going to have a Coke or Pepsi vending machine. Whichever one's going to deliver it to me cheaper, that's the one we'll do. And I think that's probably the way it's going to have to go. A lot of the insurance companies are not covering it. I know CVS Health and Cigna are looking at using it to expand their pharmacy benefit divisions. Certain Blue Cross plans are covering it. However, individual ones have posted losses, and they've cited that. I want to talk about that study that says only 6 in 10 don't reach a meaningful health benefit. Now, this is going to be a little bit more cynical, Matthew Handley here, talking about that you can have a person in a white lab coat, come up with whatever result you want in a study. That's how I was kind of reading this, as a way to try and push back against these claims that there are not health benefits for it, and they should not be covered by Medicare, which means it would have to be covered by Medicare Advantage and shouldn't have to be covered by the commercial insurance. What do you think about that take on this study?
No, I completely agree. That was, with no more basis behind that than this statement of 6 in 10. The immediate thought that in my head, and again, I have an advanced degree in statistics, is Harry Truman was absolutely right when he said there are 3 kinds of liars in this world: liars, damn liars, and statisticians. So, I mean, I can pull data to make anything I want, say whatever I want to from a statistical perspective. And I think this was picking your study, your sample, your setup to create a statistic you wanted to push back on covering. I understand right now why the insurance companies are worried about covering something that could affect this many people and cost this much money. But I don't think the right solution is just to not cover something that, again, pretty much everybody agrees for the right patient has a massive clinical benefit. My physician is very, very hesitant of prescribing medications. And for years, there wasn't a single weight loss medication that he would even think about prescribing, because he said, I don't like them. I don't like that they do. And when Wegovy came, he said, I know this drug. We've been prescribing it forever because it's Ozempic at a higher strength.
Yep.
The studies are good. The side effects are not harmful. They can be, that makes you feel a little bad or whatever. And it's effective. And so I'm going to prescribe this one. So we got to find a way to do it and do it effectively to really help what is a huge problem in this country. And we can't break the bank. I get that. But just saying, oh, well, we're going to make up a statistic that shows this doesn't work. No, let's not do that. That's garbage.
Well, and kudos to Becker's Hospital Review, and we'll have this link in the show notes and on the website as well. And part of it, the headline is a little bit dishonest here, because it talks about 6 in 10 don't have a meaningful health benefit. But when you dive down into some of these key takeaways from the study, 6 in 10 patients stopped using it before they had a meaningful benefit.
Right.
And one of the things that even Blue Cross admitted in here is, well, you have to take it at least for 12 weeks before you achieve weight loss that will positively impact their health. That's according to Blue Cross in the study. Obviously, anecdotally, other people may have different experiences, but that goes along the line of, I'm going to try a diet for a week and I'm not seeing weight loss, so now I'm going to give up. Well, you can't then have the headline saying 9 in 10 people that tried this diet didn't work, when 9 in 10 people gave up after a week. That's one of the things that it's interesting where the headline was particularly dishonest here. Now, granted, we don't know why people stopped taking it. It could be that they didn't want to pay for it anymore. Insurance stopped covering it. Whatever the case may be, that's not why it's not working. It's because people stopped taking it.
Right. And the same thing would happen if you took a statin to lower your cholesterol, but only took it for 6 weeks and then said, well, you didn't get meaningful benefit. Well, I stopped taking it. And the other thing people understand about the drug, why you've got to take it for a certain period of time, because you've got to titrate up. You start out at a very low dose. And then you titrate up every month to a higher dose. And the higher dose is where you start to have more meaningful weight loss, but you don't want to start with the higher dose because it's sort of too much of a shock to your system on how you feel on it. So
Sure.
yeah, that's why I say it's like, liars, damn liars, and statisticians.
Right. As the last kind of question for this topic, Ron, obviously I think it's coming down the pike that it's going to be covered either by commercial insurance or Medicare or both. I'm a big fan of generics just when I go to the grocery store. Big fan of generics when I do get prescription medications. How long do you think we'll have to wait before we have a generic Wegovy or Zepbound or any of these other weight loss drugs?
Well, I think it's going to be years before we have a generic, because you're going to have them, they'll be protected for quite a while. But again, we don't need a generic, since I'm paying out of pocket. Okay. And it's not like I know the CEO of Zepbound. I could go online, get a special, since my insurance company doesn't cover it, and I get a special discount card, a $1,200 a month medication I pay $500 a month for. $500 is still too much. But if they're willing to cut their price more than in half just for me, and I'm only buying it 1 month at a time, what happens when IBM says, hey, which guy is going to,
Sure.
Does it get down to 100 a month, 200 a month, 300? If you start looking at a Zepbound or a Wegovy at, let's say, $250 a month, now the benefits are enormous because that's really not that expensive of a medication for what it does. So that's why I said, since there are two good drugs out there, I don't think we need a generic.
Sure.
That'll be great when it comes. We just need to let the market and start, picking one over the other, make them compete.
Do you think it's also a little bit of economies of scale? Do you think that once you lower the price and are able to sell it to more people, you'll be able to lower the price more? Do you think that'll have a role in this as well?
Well, it could. I mean, the weird part right now is they can't keep up with demand, even though it's not being covered. Neither company can produce enough. There's shortages all over the place.
Okay.
And so once their production gets fully up to speed, then I do think they want market share. They want to sell more. And then we'll get into this. Well, I'm willing to do it for 300. Are you willing to do it for 250?
We'll have the link to some of Senator Sanders' remarks on these GLP-1s, as well as the takeaways from the Blue Cross Blue Shield study in the show notes as well. Ron, AI right now is one of the hot button issues. I hear more and more about AI every day. I have used ChatGPT for different applications outside of work because of the way that it can shorten some tasks for me. United Health Group's CEO, Andrew Whitty, who we talked about a couple weeks ago, spoke at a conference last week and talked about how AI is some of the low-hanging fruit that they're trying to use to speed up administrative processes. Call me a skeptic or a cynic, but I'm not sure that this is necessarily going to have a benefit to patients or physicians based off of what we've read about Cigna's use of PXDX or even UnitedHealthcare's use of other auto-denial systems. What do you think about United Health Group increasing its use of AI?
Well, the first thought that comes to mind is, that old joke about, what the difference between a pessimist and an optimist is? Experience. Okay. And that's why we're skeptical here, because all of our experience says that they don't use these things for the betterment of patients. That whole thing with the Cigna PXDX and the whole thing with, what's going on with Change Healthcare with United and why they didn't fix that earlier. Our experience tells us that insurance companies do what are good for insurance companies and not necessarily for patients. I agree with him that it has a lot of potential. AI has enormous potential in a lot of ways to help, much like, when you go all the way back to the Industrial Revolution or the difference between, the computer versus a typewriter. These advances in technology can produce very helpful, but I think we all should have a very healthy dose of skepticism that that's how they'll be used initially. And that's what we need to hold them to it is don't just do these auto denials. Don't have a computer read a medical record and say, well, I know what happened here, and I'm
yeah.
going to make a determination on that.
Do you think, and of course this goes into another area that I'm skeptical of is over-regulation, but do you think that this is an area where we're going to have to see at the federal level some sort of regulation over how AI gets used, not necessarily on the medical side of healthcare, because we had that great conversation with Radiology of Indiana about how they're using AI to do AI and radiology and what that can do. But on the administrative side of healthcare, do you think that there ought to be some sort of federal regulation there to kind of create some guardrails that are going to protect patients from having coverage denied and to protect physicians from having claims denied?
Well, I think you've got an option there, and I'll tell you what my preferred option is. You talk about why people aren't as worried about it on the clinical side. Why aren't we worried that radiologists are just going to use AI and they're going to write reports on that, and a radiologist will never look at a study and they'll bill all those things? The reason why we're not worried about that is they know if they miss something, they can be sued, and sued not only for large amounts under malpractice, which it would be, but also they can lose their license. Mm-hmm. So they're policed by the fact that bad things could happen. Now, the concern I have when you get on the payer side is there's no police there. There's no risk that they have. They really can't be sued because they hide behind, well, I was making a payment decision, not a coverage decision. So I think you get one of two options. You either have to open up the ability for patients to seek action against their insurance company when the insurance company does something bad to them. Right now, the patients have almost no ability to do that. Or you're going to have to federally regulate it. Now, I'd much rather open up the patient ability to sue, because that works very well on the delivery side. It's a little bit like, I'm a hockey fan. And one of the things I like about hockey at the NHL level is if you take a cheap shot on somebody, you know what? Later in that game, you're going to have to drop the gloves and fight somebody else. And the game polices itself that way. If the payers were using AI poorly and patients could then sue them and successfully, it would police themselves.
Mm-hmm. We'll have this linked in the show notes as well. Ron, I want to switch as our final topic today, kind of a weird healthcare news. This is about a former executive for AstraZeneca who is facing federal cyberstalking charges for allegedly sending violent threats to executives at CVS Health and Aetna after he had issues with personal claims reimbursements. Now, for all of us that have had a claim denied, I think we've all thought about what we might say to those executives. This guy went ahead and did it, and he's been arrested and charged with cyberstalking. I was sent this over to you mostly as a hey, this is weird, and I'm curious what you think about this particular story. And I mean, obviously this person doesn't work at AstraZeneca anymore, but so we know what happened as a result of this.
Well, to me, there's two things. First of all, let's just be clear. That's never okay.
Yeah.
Threatening people is I'm not at all, condoning that or anything. Now, the other side of it is, well, I can understand it. I can understand, and I don't know the details behind what was denied or whatever, but I can understand dealing with a very difficult medical situation, the stress that puts on you and your family, and then having some nameless, faceless insurance company tell you can't have certain care. Mm-hmm. And sometimes those denials are just so out of the ordinary frustrating. I have a friend who attempted suicide. Thank God he was not successful. Mm-hmm. And part of his treatment afterwards, his post-treatment that was, I think, very necessary, got denied originally by Blue Cross. And one of the reasons why they said that it was denied was because he couldn't prove that he was a danger to himself or others. You mean the attempted suicide wasn't proof? I mean, and then the other one was, well, because there was no sort of comorbidity between his potential depression and alcohol abuse. Well, he drank a bottle of bourbon before he tried to kill himself. So was that not, I mean, sure, and you can imagine somebody dealing with something that difficult and getting this, are you effing kidding me that this is the way you're going to deny this? I can understand somebody going, well, I'm not going to stand for this. I get it. It's not right. He shouldn't have done it. He's obviously paid the price for it. But I also think we should sort of take from this story, what on earth does a payer have to do to make somebody do that? And they do it every day.
Mm-hmm.
And then it gets back to our previous, and what recourse, what responsibility do they have? He obviously felt like he had to do this because he had no other ability. There was no way for him to, to effectively appeal this, to sue Aetna, CVS. So that's the other part of this is why do we have an insurance industry that forces people into thinking this is their only option?
Mm-hmm. We'll have this link as well. The full complaint will be linked in this article, and just as a warning, if you are going to look at it, there is some graphic and vulgar language in there, so that's your parental guidance suggested on that link. If you're going to take a look at the link is within the Becker's Payer Issues article, so if you click on that just as a fair warning that is there. Ron, we've talked about a lot of issues today. We've also had some really great interviews over the past few weeks. I want to let people know that coming up in the next few weeks, we'll be talking with Dr. Gus Garaci about electronic health record systems, as well as some other advancements in healthcare. And we'll also be talking with former Cigna executive Wendell Potter. That should be a good conversation as we talk about Medicare for All, Ron. And I'm excited for both of those. And if you want to make sure that you're getting all of them, be sure to subscribe to the Flatlining Podcast wherever you're listening to us today. You can also find us on YouTube and flatlining.net. Be sure to share it with your friends, like us, and believe it or not, giving us 5 stars and leaving us a review on Apple also really helps share the program. We are growing very quickly. We've grown a lot over the last couple of years thanks to you listening to the program, and we do appreciate you sharing it with your friends as well. It means a lot to us that you would turn to us here at Fulcrum Strategies as your resource for what is happening in the healthcare world. Ron, we're just about out of time today. Thank you very much for joining me, and hope to talk to you again next week.
Sounds good. Thank you.
An episode of the Flatlining Podcast. Well, now you can read a recap. Just go to flatlining.net and look right there on the homepage every Monday for a written recap on last week's episode.